experience. So without further ado, I'll request Dr. A.K. Mandal, Senior Faculty at L. Prasanna Institute, deliver his talk on accentual renal anomaly and of course syndrome complex, how to be diagnosed and managed. You have about 10 to 12 minutes for this book.
Thank you, Dr. Murli, for including me in the instruction course. I do not have any financial interest to disclose. Title of my talk is Axenfeld-Rieger Anomaly and Syndrome, a Diverse Clinical Spectrum. More than 100 years ago, exactly, in the year 1920, Axenfeld reported a case where there was a prominent line in the inner aspect of the peripheral cornea near the limbus, and there were iris strands attached to it, from the peripheral iris to the line. Starting 1930s, Rieger reported similar findings but with additional changes in the iris. Later on, this was known as Axenfeld's anomaly, Rieger's anomaly, Rieger syndrome, Axenfeld-Rieger syndrome. It is a syndrome complex, it's a manifestation of the disease, and here is a situation. A newborn baby presented with a bilateral appearance like this. Cornea is little hazy and prominent solvable line is there. And when we saw the baby, I was interested immediately. I'll come to this story later on. Immediately interested in seeing the eye of the mother, and we saw similar finding. The finding can be associated with serious change or the extensive change in the iris in the form of iris atrophy, correctopia, ectopia, UV, etc. In some of the situations, there may be associated dental abnormality and facial bone abnormality. Now, the common features of this syndrome complex is bilateral affliction, positive family history most of the time, no gender predilection, frequent non-ocular developmental defects like dental defects and bone abnormality, and the high incidence of secondary glaucoma. Glaucoma can happen up to over more than 50% of the patients present with this syndrome. Here is the artist diagram showing what are the structures in the anterior segment involved in the process of developmental abnormality. Presenting a case of Axenfeld-Rieger anomaly which was associated with extensive changes in the iris and iris hole formation. Look at the gonio anomaly. The iris attachments from the peripheral iris to the prominent solvage line, which is very typical of this syndrome. Presenting another case where it was associated with extensive change in the corneal endothelium, as you can see here. Now, as I told, more than 50% of the patients will have glaucoma, and glaucoma can manifest at any age, at birth, in the form of congenital glaucoma, like primary congenital glaucoma, and some of the cases will present later on in early childhood to young adulthood. Now, when it presents at birth, it mimics, congenital glaucoma associated with the anterior segment change, which I have just described. The mechanism of glaucoma are multifactorial. Like primary congenital glaucoma, there may be gonio anomaly, where the iris is inserting directly on the trabecular meshwork or the angle separation has not happened. In addition to that, there are changes in the Slem's canal trabecular meshwork complex. In some of the situations, in the advanced stage of the disease, actually, intraoperatively, we cannot locate Slem's canal because of just the fact that advanced stage can lead to dysgenesis or atrophy in the structure of Slem's canal. Noel Rice, in the year 1977, presented a series of patients where the results of goniotomy is extremely poor to the extent that he finally commented goniotomy is probably contraindicated in case of Axenfeld-Rieger anomaly. One important thing is if it is associated with corneal edema, technically it is difficult. Additional difficulty is in the gonio abnormality where the iris strands bridging from the peripheral iris to the prominent solvage line. Compared to gonio anomaly, probably alternative technique of trabeculotomy ab externo is still possible. You can dissect the Slem's canal. If the Slem's canal can be dissected, with the metal probe, you can do the trabeculotomy part. In the process, you can see the tension on the prominent the iridocorneal adhesions, and that is there, no problem, you can do. In most of the cases, we prefer to perform primary combined trabeculotomy and trabeculectomy, thinking that the trabeculotomy will take care of the goniodystenesis, and the trabeculectomy part will bypass the episcleral venous pressure and directly drain the fluid from the anterior chamber through the ostium into the subconjunctival space. And that's the reason we feel that this is the ideal technique for this difficult situation. Here is the surgical intraoperative technique. Trabeculectomy is being done, then the iridectomy, and then the conjunctival closure is done with atriovital suture. Long ago, in the year 2016, we looked at the 20 years data, 1990 to 2010. We are interested in what is the result of primary combined trabeculotomy, trabeculectomy in early onset glaucoma. By early onset, we mean at birth or neonatal onset, plus when the patient is presenting with glaucoma within 3 years of age. And here is the Kaplan-Meier survival analysis. Success rate of 93.3% continued till about 5 to 6 years of follow-up, and then the surgical results decreased. When we looked at the qualified success, addition of 1 or 2 anti-glaucoma, up to 2 anti-glaucoma medication, then again the control of intraocular pressure was achieved. What is required is lifelong follow-up and the long-term IOP control. You can see the pre-operative and 1 year post-operative appearance of the right eye of a child who was operated by primary combined trabeculotomy, trabeculectomy, and you can see how beautifully the corneal edema cleared, and you can see the Solvay's line. The other eye, the pre-operative and 1 year post-operative appearance, so similar, positive result. Here is the 3 years post-operative appearance of the blade. You can see diffuse blade and with microcystic changes observed in slit lamp examination. But this is the appearance of the blade without use of any antimetabolite or antifibrotic therapy. I personally do not believe in using antifibrotic therapy when we operate for the first time in congenital onset or neonatal onset glaucoma because of the obvious problem in the long-term follow-up. Chances of blade-related infection, uveitis and endophthalmitis and chronic hypertrophy may be an important consideration. So, because I do not use intraoperatively mitomycin, what I have done is changing the surgical technique just for the number of sutures. Triangular-scleral flap, limbus-based conjunctival layer, limbus-based triangular-scleral flap. At the end of surgery, closure of the surgical scleral flap is done with 1 tenonylon suture at the apex, avoiding the side sutures. It's a tricky thing. Somebody may argue that it can lead to chronic hypertrophy in the early post-operative period. If you meticulously perform the surgery, none of our patients required actually reformation. Coming to the topic, a clinical manifestation in the 2 generation actually. The boy here and the girl, his mother was the patient clinical picture but no glaucoma. This is the appearance of the anterior segment, a 1-week-old child, immediately, it's a neonatal onset glaucoma. When we saw, it's a very thought-light examination, diagnosis is very well established with that. But immediately I looked at the mother of the child. Mother had similar typical findings. I was interested in asking, is there any other sibling? Yes, the elder sibling was there, but they could not drop the child, elder child. I was interested in seeing that in successive visits. They brought the child, we examined. We did primary combined trabeculotomy, trabeculectomy for both the eyes in the same operative session, continued for 5 years follow-up. We saw at 5 years, because of trauma, the right eye developed problem and it was thicical. The other eye having normal vision without any anti-glaucoma medication. Here is the child. We followed for about 13 years to establish that yes, glaucoma is developing, and then we operated on the child one by one, first on the right eye and then on the left eye, combined trabeculotomy trabeculectomy. You can see ASOCT picture of the child, and the child developed a field defect at which we decided to operate, and here is the mother's eye. Typical feature, typical gonio anomaly, severe fall, but no glaucoma, followed up for about 25 years. So here is the diverse clinical manifestation. Optic disc is normal of the mother and the field charting is normal. So here is the family, a perfect example of axon-filled rigor anomaly with diverse clinical manifestation. So thank you. This is the
for the comprehensive overview. Sir, are there any set of cases where you advocate doing a genetic screening? Because we have seen as a cornea specialist, particularly families with a FOXC1 mutation.
yes.
They have endothelium similar to the Fuchs, and the cornea tend to decompensate.
Yeah, the genetic study is going on. Each and every patient of this kind are included in the genetic study. As you told, FOXC1 is the then mutation. Okay.
But what has been your experience, axon-filled rigor syndrome?
Basically, there's an overlap. Generally, we tend to send them to the glaucoma specialists, and so Shikha and Vinay Gupta are the ones who would be able to give you the comparative, experience. But the beauty of that surgery, where you see that operated drab, with that very beautiful result, I must say. And I had a little curiosity from the cornea point of view. There were two eyes where you had shown that prominent Schwalbe's line is more like a D shape. And the rest of the cornea is clear. So it's very interesting because it's supposed to be prominent Schwalbe's line. It's come sort of paracentral, so what is beyond and the cornea is clear beyond. So it's very fascinating. Do you have ASOCT of that patient? Okay. Of that mother also. Very curious, and it is specular in that area also. So that probably confirms, I think, that there is some degeneration of the endothelium later or something.
So we did the ASOCT of the mother and all the children also. Mother was having bilateral severe clinical picture, but fortunately there was no glaucoma. We continued follow-up for about 25 years plus.
Yeah, great question, madam. We just recently published, we've done a swept source imaging. So, sir was showing, the prominent embryotoxon, which is like a stub arising from the corneal stone. So, earlier we used to believe it is a thickened termination of the Descemet's membrane, but it is directly arises from the stone. So, I'll be talking to you on repurposing lipokeratoplasty. I'm sure many people who've been doing keratoplasty for a long will connect to this terminology wherein you eccentrically refine the corneal donor to include the healthy limbus. I'll come to that, why do we need a lipokeratoplasty in sclerocornea? Do not have any relevant financial disclosure. Sclerocornea is one of the very rare and a severe developmental abnormality of anterior segment. It often characterized by dense corneal opacification, extensive vascularization, and ill-defined limbus. And these parasites are supposed to be inadequate. And corneoscleral adhesion constitutes one of the important poor prognostic factors because the risk of glaucoma is much higher. Therefore, conventional PK tend to fail you. Also, these corneas are extremely small. If you look at phenotypic description of a sclerocornea, where you have a scleralized kind of a cornea, ill-defined limbus, and this is supposed to be corneoscleral junction. This is where conjunctiva is anteriorly inserted. It is mechanistically to explain. So this is perhaps due to transcription abnormality. So during the neural crest cell migration, So possibly one of the downstream pathway getting involved because of one of the transcription factor that lead to ill-defined. You can see the ill-defined limbus. This is not the normal limbal palisade which normally seen, and a dense corneal opacification. And cornea gets vessels not only from the episclera but the sclera. And they also have an absent Descemet's membrane and extremely small cornea. And you have an extensive peripheral corneal adhesion. So this is the perfect recipe for a graft failure. Meaning, it's a nightmare for any corneal surgeon to attempt keratoplasty in the sclerocornea. In all these cases need a uveum. You can also see a thick iris which had an extensive peripheral syndicate. This particular case also had normal pupillary out and had a anterior cataract. This has to be distinguished from the peripheral sclerocornea. You have a relatively central clear cornea which is extremely flat, less than 28 is a K value. And you have a peripheral scleralization, which is again exactly similar to that of a sclerocornea. This is essentially basically a Kera gene is involved, type 1 and a type 2. So this has to be distinguished. And this particular entity doesn't need a keratoplasty. Or we need to give a refractive correction, maybe in the tune of 10 to 14 diopter of hyperopia. This has to be recognized early. Otherwise, we end up having intense hyperopia. One of the OCT or UVM pathognomonic sign is a discoid-like cornea. The central cornea is relatively thicker compared to the peripheral. You can see a mid-peripheral, there is a thinning. And they can have an extensive syndicate formation depending on they have a type 1 or a type 2. And again, the topography is showing a less than 30 is the pachymetry. It's almost, like a table down. Coming back to histology of sclera, you have an abnormally thickened epithelium. And there has been always a debate whether the phenotypically belongs to cornea or a conjunctiva. And immunocytokeratins showed, pendulum swings on both the sides, although they don't have a goblet cells, but they have a manifestations of a conjunctiva. This in turn, indirectly pointing that there is a stem cell inadequacy in this. Meaning, post-operatively, it may not be able to maintain the corneal epithelial homeostasis. And I'm sure all cornea specialists would agree with me, post-operatively they have a recurrent epithelial breakdown that is a starting or a trigger point for a cascade of event leading to the graft failure. Moments is always scarred and absent. And as I said, thickened irregular collagen fiber, they're not only thick, wavy, they're also reminiscent of a sclera. Although chemistry showed they belongs to type 1 fiber, belongs to cornea, but there is a sulfated keratin sulfate. This is an abnormal thing that also invites vascularization, that also leads to corneal opacification. As I said, you have a fluoride episcleral and scleral vessels that again makes these grafts extremely, high risk for a transplantation. And studies are consistently show either the DM and endothelial complex rudimentary or a completely absent. And one of the most important risk factors is a dense peripheral iridocorneal adhesion. This can be one of the independent risk factors. You go release during surgery, within few weeks, the syndicate again forms, people get distorted, and you can see an extensive vascularization entire cornea. We did a immunophenotyping, although it belongs to that of a cornea, but you have a irregular, thickened, wavy corneal stromal collagen which are oppositely arranged, and you have a sulfated keratin sulfate. This is one of the important culprit for vascularization. I was thinking, the limbal and algae also get affected based on the type of a transcription abnormality we are dealing with. So they always have a limbal inadequacy. While I was with Pittsburgh with Ken Nischel, I did this particular work. So my question was simple: why do some sclerocornea tend to do exceedingly well and large majority of them won't fail? So that was my research question when I went and spent 1 year with him. You can see these are the normal healthy palisades measured with the OCT. These are the abnormal palisades in the sclerocornea cases. So what we found, to maintain normal epithelial homeostasis, we need to have 5 to 6 palisades per every square millimeter. That is the minimum number required to maintain the surface homeostasis. If you look at this is a classic aniridia where you have a primary congenital stem cell deficiency, and although the immediate postoperative period, graft is looking good, and it went on a downhill course, we end up having a failure. So what causes sclerocarnia? As I said, this is basically transcription factors, which are basically controlling the messenger cellular differentiation of the primordial cells, which are responsible for the neural crest cell migration. Since between the 6 to 8 weeks, you have a 3-wave of neural crest cell waves, which gives to different tissues in a cornea. So basically, this one of these aberrations can lead to sclerocarnia. If it is a PAX6, they can definitely have an extensive stem cell deficiency. So is a FOXY1. So variety of things, and nearly 50% of our study population either autosomal dominant and recessive, other 50% sporadic. Sporadic tend to do much well compared to the familial autosomal recessive. And repeatedly the studies have shown, I'm sure you all agree with me, within the first year, 70% of these grafts deemed to fail within the first year. So therefore, we wanted to see, based on my primitive study on the ASOCT, can we combine the old technique where we used to use a limbus. So this is an index case. You can see the right eye, where we defined limbus and hardly had any palisades. He had a sliver of superior-temporal area where you have a sliver of healthy limbus. I'll take another 3 minutes. So this is a regular video. I tend to respect anatomical landmark. I'm sure there may be inadequate palisade and they are not totally absent. I'm giving a benefit of doubt. And also reinforcing whatever stem cells we have. And you can see a lot of signage. This is almost 10-year-old video. Our recording system then were very primitive. And if you carefully look at, these are young tissue, less than 40-year-old, with a 6 hours of DPT. I instruct my IVAC team to include a small frill of conjunctiva. Actually, I trimmed it because I'm a little scared, obsessive, leave behind a lot of conjunctiva that can have a conjunctival commensal risk of infection. So essentially, what we have done, we also included a limbus. In addition, I put a contact lens that helps minimize the surface inflammation, premature loosening of suture. If you look at, this child just skipped, the 1-week visit, and the left eye, contact lens had come off. Look at the right and left eye. Within a week's time, you have all the sutures are loosened up. You have a lot of mouth and cornea very edematous. And thankfully, with the immunosuppression, able to recover. Although this cornea is not pristine compared to the right eye, but child is doing very well. Otherwise, normally sclerocarnia, we discourage this parents, nothing can be done because we end up losing, we are converting it to painful blind eye. At least child may have some ablated vision. If you don't intervene, if we intervene, we may end up, this is basically, this has been both in Europe and America, they follow that even to the date, they don't operate sclerocarnia. But in our scenario, it's different. There are a variety of cases, and all of them have, you can see the part of the limbus, which helps maintaining the postoperative epithelial milieu. I'll skip, the interest. I'll just talk to what are the complications. Mostly, you have an irreversible resection, 25%, meaning, it is such a fluid resection. Even if you immerse child in a steroid, it is unlikely to recover. They went on to develop graft failure. The reason is, graft is only 6 millimeter. With our modified technique, at the end of 1 year, we had a 68% grafts were clear, around 60% at 3 years, 2 years, and at 3 years, 50%. Meaning if I'm able to keep the cornea for the next 3 years clear, at least 50% of them have had the visual cortex stimulated during neuroplasticity. I always have a window of opportunity to revisit or do something for these cases. And we could also capture endothelium in such cases. All these cases, based on bilaterality, unilaterality, and number of palisades. If they have inadequate palisades, there is a risk of epithelial failure sclerocornea. I'm dealing with only total sclerocornea, so then we can use a modified technique. And addition, use of contact lens, topical or systemic immunomodulator would really help. Why do we choose topical immunomodulator? Maybe child may be unfit for the systemic immunosuppression, and also it is a cost is prohibitively expensive. The family has to spend nearly 7,000 to 8,000 for a bottle of cyclosporin for every 1 or 2 months. With this modified technique, we could fairly achieve a good outcome, and this can be extremely a good, safe, effective alternative, viable alternative to conventional penetrating keratoplasty when it comes to sclerocornea. So before I end, there is also a concept, Radhika Madam and Bharati can chip in here. In the late 60s and 70s, there was a concept of immune tolerance induction. There are the T cells. So as an infant acquires a passive immunity from a mother, B cell, and a T lymphocytes. We exactly do not know the critical parameter. Maybe immunological studies have shown between 3 to 6 months is the time frame where lymphoid system is establishing in a child. So if we identify that window and do the organ transplantation, child would accept the donor cells as our own, and therefore we can actually minimize the risk of rejection. So that's called immune integration. So we can identify there are a variety of ways we can actually minimize the rejection process and salvage this visual access, particularly during the neuroplasticity. Thank you for your kind attention. If there are any questions, I will be very happy. So this is in Malaysia. So I'm organizing one particular session where interested people can reach me. So love to have you in Malaysia. Thank you. How do you are approaching our sclerocornea?
Similar to what you have mentioned, some of the cases you can retract the conjunctiva, and because it's not like a uniform phenotype, so that happens that one can do. And similarly, we also use the bandaged contact lens. If it's very, very dense, then you can do the manual debulking. So you can, because in your case, you can see that the intraocular structures were very intact. So if you do a blind entry, sometimes you may inadvertently damage the iris and the lens. And so I feel that it's a similar kind of approach.
This through my presentation, once I just showed about, and when I was talking about a limbal translocation, this one. So you actually carefully do a peritomy and take the palisade back. I've done that one. Provided these palisades are healthy, they definitely they'll sustain. But in my case, in technique, I do not touch this one because if you have a micro niche environment, the very process of doing a peritomy, they may destroy. And there are people who attempted even a slit. I'm not a big believer of magic, so I generally retain whatever was and place it. I agree with you, man. I was a reviewer for this particular paper from a Chinese group where they used to do a limbal translocation, meaning this peritomy they do, and they end up doing a large 8 millimeter, 8 or 9 millimeter, and you have extensive pores and converting it into super iris graft, so which I generally do not believe. And I request Professor Radhika to do a presentation. Dr. Bharati and Veena Lakshmi, you have a different your perspective of dealing with this sclerocornea.
What is the earliest stage of the surgery?
Extremely good question, sir. In a unilateral, we do 2 months. In a bilateral, 3 months. This is we've done from a pedi group, pediatric, cataract eye group study, where they defined a critical period for a unilateral cases, 6 to 8 weeks. Meaning, if we do within that critical period, we would be able to, support the visual system maturation. And some of these sclerocornea bilateral cases, even I've done up to 3 years, so they generally do very well. I know I'm not giving 20/20 vision, even a 20/200, 120 vision, which helps child to navigate, go to regular school. So that's a very important.
Associated with cataract and all that. When are they treated?
Excellent, sir. Even if there is a mature cataract, I won't tackle simultaneously because combined procedures tend to have extremely poor prognosis. I revisit So within a month's time, all sutures are out. Once inflammation, everything is taken care, maybe about 3 months, 6 months, you will go on to a cataract. But you do a cataract, you have to do PPC because the PCOS, you can't put an intraocular lens. Okay. So and cornea will never like vitreous fluid. So they need to fail. If you have a cataract in these cases, then it is a vicious cycle when you have a failure.
How to ensure that bandage contact is remain there for it's basically about
Excellent case. So this bandage contact lens is 18 millimeter, and I do mandatory dorsography, two-third with dorsography. Unless the parents or the child is little older. That's what if the child is less than 6 months, he or she doesn't have hand-eye coordination, so they tend to do very well. If it is 1-year-old, 2-year-old, problem is gets tripled. So they just pull it in one go. Great question, sir. Thank you.
I think I agree with Murli in all these difficulties, and the simple thing which I do is give them a patch at least till the epithelium heals, and ask the parents to keep removing and keep putting the medications, because once you have BCL, it tends to get dislodged. And again, always have a cartella on for these patients, because you do tend to get a higher incidence of graft versus disease because of trauma in these patients.
And also this was specialized contact lens made from Israeli, no financial disclosure. They tend to keep the drug in a sustained way up to 9 hours, so that mother doesn't have to instill every hour steroid. It has 8 fenestrations and it channels, numerous channels. With each blink, it creates a negative pressure. The contact lens, retro contact lens teofilm get recharged with the prednisone.
Thank you, Dr. Murli, for involving me in this session. So talking about developmental abnormalities of the cornea, we have a variety of congenital corneal opacities. The areas of interest that I will cover: Leiter's anomaly. We have corneal dystrophies, microcornea, microphthalmos, aniridia, sclerocornea, and the various ectasias. Regarding sclerocornea, there is a recent move that it just put everything as anterior segment developmental abnormality. But the word sclerocornea is useful because it helps to differentiate certain phenotypic features, as Dr. Murli said. Generally, looking after these patients is a multidisciplinary approach involving pediatricians and ophthalmologists who are specialized in cornea, glaucoma, as well as pediatric ophthalmology and strabismus, and along with geneticists. And I'd like to add an extra role of engineers, because it's the technology that we have that is improving our diagnostic and therapeutic skills. The role of anterior segment imaging cannot be overemphasized, but there are challenges in documenting the features in such small children. And here a simple cell phone based camera can be better than no image at all. So a clinical photo, corneal tomography, ASOCT, UPM, and confocal microscopy judicially used as suitable. I'd like to explore the shared experience we have of exploring the application of AI. The purpose is that when you have very specialized doctors, very specialized centers, there are few and far between. And often when a child is born, a baby is born, they would go to the local ophthalmologist. So we wanted to see that can we have a system of having a better screening and giving an aid all across the country, and whether the system could work as a tool for early differentiation and triaging of the patients. So largely, the conditions that we considered were CIGB, and this is an exploratory pilot study to see if this could work out in the future. So we could check primary congenital glaucoma and Peters. And here again, I want to emphasize that when you have people in the room like Murli, Vanati, and Dr. Mandal, Meena, for them it's not so much of a challenge. But when you go across to the other ophthalmologists, it may be a little bit difficult. And what are the features in this that could be confusing? One of the points is that patients may come also a little later. So therefore the textbook description may be modified. And the other thing is that there is an overlap, as we are now learning to understand. There is a lot of variation. So looking at the whole list, these are all the various parameters that we thought that we need to use them, and from a case-to-case basis, it's all right, but you may see one patient, you may see another different one after 1.5 years. These are not very common diseases. So the brain is not trained or properly equipped to differentiate. So we thought that if you have a computer algorithm, it can overcome these weaknesses of human frailty. So this is a preliminary sharing of our results. So we have included 42 patients, 82 eyes were included for analysis, where we had these diseases, as I told you, and we looked at the age, the sex and the gender, and it was found that Chet presented a little later compared to the other two groups, and Peters is the one which appeared earliest. And male, female, there was no difference. Then looking at other demographic detail, the significance of then disease comparison, disease against disease. So Chet versus PCG, there was significant difference. So Chet has a tendency to present later. And again, this could vary because we do not know what is the situation in other parts of the country. So this is the cohort that we studied, maybe a pattern seen in North India. So it would be interesting to see if anybody else has a data, then maybe we could consider variation and a collaborative kind of a comparison. Chet versus Peters and PCG versus Peters again. So we found that Chet versus Peters also there was a significant difference, but not so with primary congenital glaucoma and Peters anomaly. Then looking at the extent of the corneal opacity, the density of the corneal opacity, here again there were significant differences found, where the density was much more with Peters and Chet compared to primary congenital glaucoma. And corneal diameter, as one would expect, was again significantly different. And here I wanted to emphasize because often these diseases may also have secondary glaucoma. So we have primary congenital glaucoma, and then you have, say, Peters with secondary glaucoma, but the corneal diameter was a very good differentiating feature, and that is simple to use as a differentiator. So the disease versus the vertical and the horizontal corneal diameter, they were all significant. And Ananya Kakinalkar, I'd like to mention, is the junior resident. This is part of her thesis. Now looking at the UBM, so UBM is again a very useful parameter, and now again to emphasize, it seems simple that yes, naturally UBM would differentiate, but what I'm trying to explain is that not everybody has access to a UBM. Secondly, you have to take the patient to the OR. So our idea was that looking at all the other parameters and putting the UBM, can we get an algorithm that you would say that if this is it, then you don't need to do a UBM for every patient in the periphery. That was the approach I wanted to explain again. So this was a very useful predictor, ACD iris thickness as well as the ciliary body thickness, and similarly the corresponding corneal thicknesses as well. Then we also thought that let's look at the genetic analysis, because here again this is something which may not easily be accessible, may not always be affordable, and then can we again get a pointer. So if you have this type of a phenotype, could this be an indicator of the kind of gene there was? So this was the plan, and the results of genetic analysis, we found that with Chet we had, interestingly, this subset of patients, we were able to identify the SLC411 gene in all 6. However, we have a larger subset of Chet where we have only been able to find the gene in 50% of cases. And then in Peters anomaly, we have a variation, and we have found one new mutation, and then primary congenital glaucoma, one patient didn't have any gene identified. And the numbers are very small, but nevertheless it shows that you have a disease and then you have different genes, and some of the patients the gene is not even identified. So that is something which is interesting. Then here are the definition that was used for characterization of Peters. We had type 1 was the most common, type 2 there was 1, and but only a posterior corneal defect was seen in 5. And just to emphasize a little bit about what we're talking about, the use of IOCT. So before we had done this study, we were using the IOCT screening during surgery, and it definitely makes a difference to see per-operatively what is the nature of the morphology you're able to identify, and you're able to go ahead with the surgery. This is a case of CHED, and you're able to identify any associated abnormalities. This is another patient of CHED where one eye underwent an optical keratoplasty and the other eye underwent a TSEC later on. And this is an example of a patient with microphthalmos in one eye and a congenital opacity in the other eye, and 1 year post-op the patient is doing well. This is an example of so-called sclerocornea, and here I did the technique which I mentioned. So I retract the limbus, because when the patient is on the table, you find that even a 7 millimeter circle or a 6.5 millimeter circle is going to go right through the limbal so-called stem cells or the niche. So therefore you retract it, and you still punch only the central area. And so this patient, and then I put a normal BCL, which is removed 1 week post-operatively. So we do a EUA 1 week after surgery, remove the BCL, and confirm that there is complete epithelialization, and that is what we have found in our cases. So phototomography, corneal biomechanics if the children are older, ASOCT, and then vivo confocal microscopy if the children are older. So there is a whole journey involved in diagnosis, treatment, and follow-up. There's more that we need to learn, but I just thought I'd share this experience.
Thank you, madam. That's an excellent overview. And I agree with you as well. You know, many times when we do a genetic screening, we may not get a hits. Meaning, you know, even after an appearance, doctor, you know, you ask for entire whole exome, everything. So, in such cases, it's difficult to deal with. You know, we tackle. Any questions to madam? Madam has shown a new algorithm. I think this would really help us accurately labeling the diagnosis. So it's so important diagnosis that it itself determines the the anatomical outcome. There are certain indications have a poorer outcome than certain cases. Something like CHCD have an extremely good outcome. But I have one question. When you have this SLC 411 screen, were they homozygous or heterozygous? Because you know, in southern India, since they're all parental consanguinity, most of them have a homozygous SLC 411 mutation. What about in northern India? Because why I'm asking this question, Tony Aldevey, which he presented recently, most of them are heterozygous. Meaning, you know, these parents were unrelated. They're from a different ethnic and racial groups. So I don't know what kind of thing is that. You can go ahead, madam. I think it's louder. Yes. Sure. So we'll have a questions at the end, and I request Dr. Meena to get started.
Good morning, everybody. So I will be talking about the dermoid lesions of the cornea and the conjunctiva. So we all know dermoids are a part of spectrum of tumors which are known as choristomas, which actually originate from the Greek word choris, which is separate, and omas means tumor. So the choristomas of the eye predominantly are present in the cornea, the conjunctiva, and the lateral canthus and the orbit. The other choristomas of importance is the teratomas. As is known, these are the most common benign lesions at birth. Usually, cancerous lesions in children are usually present at birth, and just like them, these non-cancerous lesions also appear at birth. But they are very distinct in morphology and can be easily differentiated from the other benign lesions at birth, especially the nevi, which come with a pigmented mass. So these are white, tan or yellow colored and fixed to the underlying structure, and these are associated most commonly as we see in the Goldenhar syndrome. So again, choristomas are nothing but normal tissue in an abnormal location. So the typical description of dermoids are an elevated firm mass, and these are usually seen adjunct to the limbus at the infratemporal part in more than around 70%. They are usually unilateral and maybe unifocal, but in certain conditions which are known as the ring dermoid, which have a mutation of the PITX2 transcription factor, they can be present as a form of a flat lesions around the limbus, which is known as a ring dermoid. Very rarely you can find that the dermoid can involve the complete part of the cornea, and these are known as epicorneal dermoid. So what are the known factors or associations of these lesions known as dermoids? These are not hereditary in predominant cases, so there is probably very little work done in the genetic associations. These are sporadic. What has happened is there is probably some problem at the embryogenesis. There is sequestration of the epidermal and its appendages into this limbal area. Apart from sporadic associations, a few autosomal dominant conditions which involve the PAX6 mutation and PITX2 mutation have been associated. And very rarely, X-linked type of recessive association and trisomy 8 mosaicism. A history of maternal infection for viral etiology has to be elicited, and if there is an association of Goldenhar syndrome, it has been shown that maternal diabetes and nicotine exposure could be associated. Mann has classified dermoids in 1950s, and this is predominantly a very useful classification because these are very simple and easy to follow. So the grade 1 tumors are less than 5 millimeters and do not reach up to the stroma or the descendants, deeper stroma or the descendants. And the grade 2 are larger, more than 5 millimeters and reaching nearly up to the descendants. And grade 3 are those dermoids which are near total, involving the anterior segment, involving the angle also. So we have a publication in 2018 where the authors looked at their dermoids that they studied in retrospective fashion of over 10 years, including 261 dermoid lesions, and they have very nicely elucidated what are the prognostic factors looking at the involvement of the dermoids on the cornea and the conjunctiva and the surface modality. So they have given points to each of these based on the severity. At any point more than 6 to 9, they said was a poor prognosis. So this was a very useful paper. I encourage all of you to read it, where they looked at the grades of the dermoids, the histopathology, and they noted the outcome was better with the grade 1 and 2 dermoids versus the grade 3, which was a predominantly involving most of the anterior segment. Histopathologically also they found that the dermoid in the grade 1 and 2 were typical dermoids showing the ectodermal origin with little bit of mesoderm. Coming to the associations of dermoid, as I already told, 30% are associated with Goldenhar. I'm not going very deeply, I'm very sure you all know. It is an ophthalmic auricular vertebral condition with a slight male preponderance involving the first and the second branchial arch. In general, it involves all the layers, all the structures which develop from these two branchial arches, and rarely they can have central nervous system and cardiovascular system abnormalities. So these children do not always come to the cornea specialist. They also report to the Orbit clinic with association of upper lid coloboma and outer canthal lipodermoid. So you have to also see these patients and pick up and refer to these Orbit clinic. So when we talk about dermoid, there is a classification not only on the morphology, it's also classified based on histopathology. A classical dermoid will have ectodermal origin tissues, basically. It will have some skin appendages and mesodermal elements. Complex choristomas have been also described in dermoid lesions where they have noticed tissues such as glands, muscles and lacrimal glands and the nervous tissue. But it's also important to know this complex choristoma can also morphologically look just like lipodermoids. When the histopathology comes as a complex choristoma, they can be associated with lid and optic coloboma. They can also have associated optic nerve hypoplasia. These patients could also have microcornea and choroidal calcification. So it's always important to go back and look at the histopathology when you excise the dermoid to see the grades of the histopathology. A very rare form of dermoid lesion is known as epibulbar osseous choristoma, where the dermoid is flat, it's between the muscles and the borders are not very well defined and they can be very adherent to the underlying tissues, where the histopathology shows a bony element like Haversian canals. They're usually seen in the superior temporal bulbar conjunctiva. So other syndromes that are associated with dermoids, I'll just quickly go in this. Look at these children for the presence of alopecia. They will have a diffuse dermoid and with a multi-system involvement, typically with a linear nevus sebaceous hamartoma, which are potential for malignant transformation. When these hamartomas are plenty, they have been given a name as encephalocraniocutaneous lipochondrosis, which have been classically criteriized with the help of Moore's criteria. They have mental retardation, and these patients probably do not come to the ophthalmologist first, and they usually come to the neurological department. They have been classified as a scalp syndrome where there is severe, large malignant sebaceous nevi. Oculoectodermal is a little less serious disorder where there is not much cranial neurological involvement, but there is aplasia, there is alopecia, and there is hyperpigmentation of the skin, not involving the midline, just like in the linear nevus sebaceous. The Delman syndrome is a differential diagnosis not for the dermoid of the ocular surface, but for the presence of appendages, just like Goldenhar syndrome where there is auricular appendages. So they present, what will these patients normally present? So if you're seeing a child at birth, the parents are very, very worried about its appearance. More than the vision, the parents are worried about the appearance. When they present a little late, they're going to ask you, what can you do for my vision? So this is how they normally present. Very rarely they come because they're not able to close their lids because of the mask between both the lids and because of a foreign body sensation because the cilia is present on top of the limbal dermoid. You have to investigate as any case that goes into the surgery for excision, include a detailed ocular and systemic evaluation, especially when you see a nevus on the face and when you see a complex looking like dermoid which is diffuse, which is not well delineated. Include MRI and CT if you want to pick up the extent of the complex dermoid or if there is a bony appearance of the dermoid. So when you have to manage a patient with Goldenhar syndrome, you have to take a multidisciplinary approach. You have the patient attend the dentist, the cardiac clinic to rule out tetralogy of Fallot. He may have vertebral abnormalities, and sometimes these problems may take more importance than the ocular. So for the grade 1 tumors which are less than 5, you may want to treat them just symptomatically, optical occlusion therapy, patching, lubricants, and just epilate the cilia on top to give comfort. So this is a surgery where we have excised a grade 2 limbal dermoid just as we do a patient of DALK. But remember, this tumor is very well integrated into the cornea. It is not as easy to remove it as a case of keratoconus where you can slice the corneal tissues. These are very densely adherent. So we want to go as deep as to the Descemet's layer to get a smooth surface so that there is no interface scarring. So we sealed it with a fibrin glue when there was a perforation. We peel off the endothelium from the donor cornea and we close both the Descemet's membrane of the corneal side of the dermoid and a little bit on the scleral side and close it with the help of a fibrin glue and deposit the conjunctiva. So one important thing that you have to note is when you operate a patient of a limbal dermoid of Goldenhar syndrome, check the corneal sensation before surgery because these patients are associated in certain cases with trigeminal hypoplasia and you end up with perforation post-operatively. So grade 1 tumors can be debulked and that area can be closed either with a conjunctiva with a multi-layer amniotic membrane or just with a it can be left even as a pterygium as a bare sclera in certain cases, and some of the authors have used mitomycin C to reduce the incidence of pseudopterygium. For grade 2 and 3 things, you have to debulk the tumor and have to fill in that area either with a lamellar keratoblastic tissue or a sclerokeratoplasty when the sclera is also involved with lipodermoid tissue, and also amniotic membrane to give better healing, or sometimes when there is extensive involvement you may have to do a corneal transplant. So whatever said and done, there is not much great outcome in dermoid surgery. There are a number of these with no a great improvement in the outcomes, possibly because this is present at birth and causes a severe amblyopia. A pre-existing astigmatism and a pre-existing hyperopia are poor prognostic factors. This is because it doesn't affect only that area of the cornea where the dermoid is present, and it actually involves all the intrinsic corneal fibers, and removing only that part of the cornea does not actually improve the vision. So just quickly going through some of the cases. So we see this young man who comes with a dermoid lesion on the temporal aspect, and when you see his vision is 6/6 and it's just a type 1, it's a grade 1 dermoid. And this is another patient that I saw recently with a lot of limbal auricular appendages, and he had undergone dermoid excision when he was 4 months old, and he wanted to know what he could do for the vision. So the other eye, which was not operated, as you will see, has maintained a good vision, and his operation at the 4 months of age had actually not been beneficial to him. So this is one take-home message, that operating even at early stage does not improve vision. Case 3, you see here the vision has improved after the dermoid excision by one line, and is also the patient has now become accepting to the contact lens. He wants to use a contact lens over this. Here you will see that after the limbal dermoid has been removed, the axis of flattening at 100 degrees remains before the dermoid excision and after the dermoid excision. So does the size of dermoid mean that the systemic associations could be less or more? Probably there is no relationship between the size of the dermoid and the systemic associations. Always see the presence of any nevus in the face and refer the patients to the dermatologist because of the malignant transformation. They could also have choroidal calcification, as in this case. So in the end, dermoids are benign lesions. The surgeries are generally safe. Most common indication seems to be cosmesis. Rule out Gordana syndrome and other neurocutaneous disorders. And if they are complex dermoids, look out for the rare associations. And in a child, when you operate for dermoid, do not forget amblyopia therapy. And also there are very rare complications like interface vascularization, pseudopterygium, and scar. Thank you so much.
Thank you, Dr. Veena. That's a very comprehensive presentation. So we'll have a questions at the end. I'll invite quickly Dr. Vanati. She'll be talking on anterior segment dysgenesis. So I'll have a quick point, before Dr. Vanati gets low. All grade 2 and above dermoid, I mandatorily keep them on a torsorrhaphy for a few years because it's difficult to ascertain the corneal sensation in order to prevent epithelial breakdown, neutropenic ulceration. So it's mandatory for me in my protocol. I keep the torsorrhaphy. Yes,
thank you, Murli. I think my topic is anterior segment developmental anomaly challenges, and all the earlier speakers have almost comprehensively covered everything. So I just thought I'll give you I'll run through a case-based approach of a surgery, and we will halt in between to just discuss the particular challenges given the restraint of time here. So this is pretty much similar to the case which you showed Murli here, and here you could see it's very difficult even to measure this cornea and find out what exactly is, do I measure it from here to here or do I measure it from here to here? You do find some amount of, corneal tissue-like morphology which is there, and you rightly showed, I had a similar picture where you could see the conjunctival insertion is much anterior here. The limbal anatomy is distorted, though you could see something similar to palisades of Vogues over here. We do find here, and also this is particularly the corneal diameter measurement itself is difficult in these. The corneal diameter is smaller; they are all like microcorneas here. And you also do not know, and when you do image on an IOCT, it doesn't go deeper than the cornea, so imaging the anterior segment, so you will have to have a UBM to look at these pictures. So this is a particular difficulty pre-operatively itself, that how would you really go about defining the anatomy in these particular patients here. And I think you have worked on looking at the imaging along with Ken Estrel on using a specialized UBM device, or the one which you use for doing venous imaging here, where you probably will be able to pick up an anomalous limbus in these patients and then say, so that is always intriguing to know which of these are going to survive and which of these are not going to survive. It still leads me to define what my outcome is going to be in these cases. So that was the starting difficulty I had on this particular case, which I recently operated at last week here. And so measuring and really tending to design, though I did have a preoperative UVM which was performed by my senior resident to help me in defining the exact anatomy here. So, but then when I went in, if you see the IOCT imaging here, you do see the cornea is significantly thickened here, and we are not able to make out the deeper structures in an IOCT, but we were able to. And it shows it shows a different image where the deeper structures seem to appear normal, or you have something like an angle which you can see in these patients here. So I went ahead, and you see it does bleed profusely here. You have a lot of vessels, and you are really skeptical. But then as pediatric cornea surgeons, we always want to give them as much vision as possible if you can, and for as long as you want to give them, so that the visual axis is at least clear in the initial phases when vision is developing, the pathway is developing. And another particular difficulty is because of the thickness which is associated, you definitely land up getting peripheral ledges when you are doing surgeries in these cases here. So looking at this, and I'll tell you why this, the UVM showed me probably a normal angle in certain places. So I was trying to define where I'm having an angle anatomy. So what you find in this case, the iris is anomalous as well, and the moment you even gently put in your iris repository, you see my iris has cut through here. And though it was not so, and I did the same procedure for the other eye of this patient much earlier. So even trying to do a pupilloplasty in these cases becomes difficult because the iris just cuts through on these cases here. So I just went ahead, and this one had a clear lens here. And again, graft oversizing is something which we do here, and I always take about a 0.75 oversize on these cases here, and did as much of a pupilloplasty which I could, and not very happy with what was possible for this particular case. So this is the left eye of this patient, I think, and recently done here, and waiting for the reports and the results of this particular case in the coming days here. I do agree that some of them do land up with suture loosening even on the second examination, which we do in anesthesia for them, and we might have to replace all the sutures. This is a fellow eye of that particular patient, which was done in 2018 years, which is almost 6 years ago. And this was a larger cornea compared to that eye, and this cornea remained clear. And this is what encouraged me to go ahead. There is a small anterior polar cataract in this patient, so I think, as Murali also rightly observed, flat corneas. Corneas are smaller here, microphthalmic globes sometimes, an anterior polar cataract, and commonly the severity of morbidity is not symmetrical, it is asymmetrical in both eyes, is what I find in these cases is a challenge. But we really do not know which of these are really, the corneal epithelialization is going to be normal, which of these the limbus is so anomalous. So I think, as Murali pointed out, looking at least 6 or more of palisades which are present is probably going to define that the epithelium is going to be healthy and heal over, and even if they do graft projection is a particular danger which always looms large in most of these patients. So to read more about it on preoperative, intraoperative and postoperative challenge, I would refer you to our latest update on pediatric corneal disease and keratoplasties, which will probably will throw more light, and I think we'll save time for a little discussion in the end.
Thank you, madam, for that comprehensive overview. Are any questions for any of the speakers?
May I ask you, Murali?
Yeah, I think, see, even I have 20 years of experience in dealing with the pediatric anterior segment. So each time when we have an IC, I learn so much from these 3 women, so that they have much more experience over the years. And we learn from each other, and we focus on doing these cases and anyone that we see. It's so important to each of these child have 80+ years of life expectancy at the time when we embark on a surgery. So it's very important to contain amblyopia at any cost. That's what my perception dealing with these cases.
few things which I wanted to, probably have our panel and we can learn from your experiences. So now I think we have moved away from calling them as Peters plus, or looking at, or calling them sclerocorneas, as what Dr. Ken Nestor strongly advocates. But I still feel calling them with the way we used to call them is helpful, at least for our fellows, because they learn to prognosticate these cases and identify the morbidities or the problems which will probably arise depending upon the severity of what we are dealing with. For example, if I just say a blanket kit, it's including also a Peters type 1, type 2 and a type 3, and we know that the prognosis is going to be grossly different from one end of the spectrum to the other end of the spectrum. So of course we moved on to name them as kids, keratoidodysgenesis or keratoido. It's basically giving names for what we, traditionally understood the way we trained here. So I think we know that the glaucoma in Peters 1 probably comes on much later, end of your first decade, or it starts affecting the posterior lobe in the second decade, whereas a simple Peters 2 and a Peters 3, you will have the severity of glaucoma much earlier on in life, and the morbidity affecting the optic nerve is much more severe, and the children tend to lose, or the control or the management for glaucoma is more refractory in these cases. Yeah. So that is how probably we all learned, and that's how we identify to prognosticate our cases, and that's something, if you put them as a blanket ASDA, it's really not going to help. And of all the ASDAs, Peters 1 and the type 1 gives us the best prognosis for most of our cases. The worst goes to the what we call as killed right now, or the type 3 Peters. And again, I think what we also look at is identifying congenital aphakias patients where they have corneal morbidities, and these definitely do very poorly. And all the kills by 10th day, I find I've lost the 10th day I've lost the graft with multiple sutures. I think so. So that's something which is a very profile, and that's something which we are still learning, I guess.
Lack of better terms, we are at this point in time using a Peters, sclerocornea. So it is a continuum. When you look at developmental abnormality, so you have a different spectrum. So it's like always, there is nothing called black and white. Shades are gray. So you have two different poles. So the pole on the left side, which is a milder variant, tend to have much better prognosis. I think key is identifying them and focusing on such cases than a walking surgery, and severe cases end up having a abysmal outcome. Yes, sir, please.
Grade 1 dermoid, once it is removed at young age or whatever age, can he undergo LASIK at later age to correct the refractor, because the other part of the cornea is gone?
Yeah, great question. Sir, if it is a grade 1, it is insignificant. It is less than 1/8 of a cornea. I don't recommend surgical excision unless child is concerned about cosmesis. As Beena pointed out, they always have a significant astigmatism leading to amblyopia. Possibly, I would recommend LASIK. The reason is you have a focal absence of limbal stem cells. So if your LASIK flap were to go up to that, you have an interface inviting epithelial downgrowth and so on. I don't recommend, sir. Maybe a PRK is a good option. Right. Thank you so much. So if there are any questions, we will take it outside.
One question.
Yes, sir, please.
Is there any relation of stem cell deficiency with limbal dermoid?
Yes, sir. They have a focal absence of, congenital absence of limbus at the area of, where it's mostly infero-temporal. That's where, it's a junction between a mesoderm and ectoderm. So it's invariably 99% are, infero-temporally located.
The stem cell deficiency?
Yes, sir. There is no limbus there. You're right.
So limbal stem cell transplantation?
Not needed, sir. Not needed because it's a very small area. Unless it is more than 8 clock hours.
We have tried and become successful
Sure.
in this way. Thank you.
Thank you. Yes.